would be interested in learning more about FoRSE. It's my pleasure to introduce Dr. Annie Peters. She has a PhD in clinical psychology and has been working in the behavioral health field as a clinician, leader, and educator for 18 years. She currently serves as the Director of Research and Education at the National Association of Addiction Treatment Programs. So we'll go ahead and turn the time over to you, Annie.
Great. Thank you, Kristen, and thank you, BestNotes, for inviting me. This is, we enjoy our partnership together with you and are really glad to have this opportunity to talk to folks that use BestNotes. So as Kristen mentioned, I am Director of Research at NAATP. A lot of people know us as NAATP. NAATP has been around since the 70s and is a nonprofit membership association that supports treatment providers of all types and recovery support providers, anyone who supports people with substance use disorders. So I, in the past, have been more of a clinician and now have transitioned into this role because I felt that treatment providers all need to understand their impact on their patients. And so NAATP started in, I would say back in 2015, maybe, thinking about how can we help treatment providers to make use of their data in a way that helps their patients and also helps them get paid, essentially helps them get new patients and expand their reach. And so we developed this program. So the FoRSE program, which I'll put up the slide so you can see what I'm looking at and do this. So FoRSE stands for the NAATP Foundation for Recovery Science and Education. And the main work of FoRSE is a 501c3 nonprofit that is sort of a research arm of NAATP. And the main work of FoRSE is the Treatment Outcomes Program, which is what I'm going to talk about today. So if you're on this webinar, you obviously know all of this information. You know, I always think in my career, mostly we've quoted 1 in 10 people have a problem with substance use disorders, and it's now almost 1 in 5. And so it's just unbelievable that this has been identified as a chronic illness and is, you know, there's essentially like commercial plane loads of people dying every day is kind of how I think of it. If a plane of people went down every day, we'd pay so much attention to it. And but the challenge here is this part on the slide that says 85% of people don't get the care they need. And a lot of that, of course, is due to not being able to afford care or stigma around substance use disorders and asking for help and getting treatment. And also, a major part of it is believing that treatment works. You know, we don't doubt that we have treatments for lots of medical illnesses, but there is significant doubt over whether the way we treat substance use disorders in this country is effective and helpful to people. So there's a lot of stigma as well. And so if part of that is, you know, and I think I've always heard a lot of addiction treatment providers get asked the question, what's your success rate? That's what always the family wants to know. The patient wants to know, what's your success rate? What's the success rate of this treatment? And in other words, they're asking, give us data. You know, what's the measurable impact of your treatment on people, on their well-being, on their substance use, and on their functioning, and on their mental health? And oftentimes treatment providers don't know how to answer that. And that's not of their own problem or their own action. This is because nationally and internationally, we don't know how best to measure recovery from substance use disorders. We don't know how to answer what success means. It means often different things to different people. So NAATP and FoRSE was created. FoRSE was created to help providers with that question, essentially. And we said, well, in order to understand what's the impact of SUD treatment, there's really 3 areas that we need to understand. If we had information from a lot of treatment providers in the country on the patient served in each for each patient episode, the service that was provided and the outcome of that episode of care. Imagine how much information we would have, with the millions of people who do get support and help. If we just had even a little bit of information about each of these episodes of treatment, we would know so much more about what helps people and how people change in the course of treatment. And so what we really need to know is just a few data points about each patient. Yes, it'd be great to have the same, 500 data points on each patient, but not everybody collects the same 500 data points. But we all do collect demographics, substance use history, mental health issues in general, and social determinants or health-related social needs, things like housing and education and employment. And then about the service, sure, there's hundreds of things we'd like to know about the service provided, but the very, very basics are, at what level of care is the person being treated? Is it recovery support? Is it inpatient residential treatment? How long are they engaged in care? And what medications do they use? And are they receiving that peer support or recovery support? If we just knew those items, and then the outcomes, we would know so much. And so the outcome is the challenging part, because if I were to ask any room of people who are working in this field, how do you measure the outcome of your treatment? We would all have different answers. But essentially, this has been reduced by many different groups, and the common factors are the person's substance use post-treatment or post-service, how they're functioning in their lives, their physical and mental health, their quality of life. And then, yes, particularly for insurance companies, but we want to know if people are using a lot of healthcare after care. Do they leave treatment and all of a sudden are still having ER visits and hospital stays because of continued substance use? So it really depends on who you ask, what is the most important outcome of addiction treatment. So we tried to develop a framework that collected just this amount of information, and we wanted to do it in a way that didn't tax providers, didn't put a burden of needing more money or more resources or more time. We didn't want to take up a bunch of time of staff people who already are overworked. We wanted to say we said, what's the most low burden, low cost way we can get this information from a large number of providers? So, we're the wrong way. So we developed this framework, and we said, what if we could get data from essentially anywhere, pull it together, and the easiest way to do it is to get de-identified data, so that we don't, there's always so much concern over patients' confidentiality, and so we didn't even want to go there. We could do a lot more if we knew more about each patient, including very, very specifics about them. But we said we can do a lot with just de-identified data. So we can get data from, we built an API, which is essentially a digital highway to get data into our repository. And then we started building these partnerships. And BestNotes was one of the first ones to come to the table and say, hey, we want to be part of this. This is important. What you're doing is important. How can we help? And they, I don't remember if you were the first or very close to the first to connect to our API, and they wrote the plugin to allow all their customers to submit this data and didn't charge the customers. They didn't charge us either. This was something that BestNotes believed in and we believe in, so we were able to provide this. And this is now available to any BestNotes customer at no cost. So you can submit your de-identified data to FoRSE, and then we try to provide meaningful output back to the treatment providers. So we do that right now in the form of reports. We're also developing a dashboard for data, but I can talk about that later. But This is the essential framework, is the data is pulled from the EMR or an app or wherever you collect data, pushed to for de-identified. And that's what's nice about the plugin, is that it de-identifies the data. So there's no patient names, numbers that would reference back to the patient. There's no way for us ever to trace back who each patient is. And so we get the data points I talked about, and then we can provide valuable feedback back to providers so that they can do better work, and also compare themselves to all the other treatment providers that are in FoRSE, which is probably the most exciting thing providers find about this program. Another thing that's exciting to us is research. It's an opportunity to be involved in research for providers, and for us, there's just so many questions we can ask of this data. We have lots of partnerships with research institutions and universities who are helping us sort through this to really answer the questions: how does treatment help people on a broader scale? This is where we are right now. As of today, we have 116 distinct treatment providers across the country, and actually one international. We have Crossroads Antigua is now participating, so it's an international program. But we have 116 providers who are engaged in the FoRSE Outcomes program. We have over 300,000 episodes of patient care represented in the data, and over 1 million surveys. And just to get a sense of the outcome surveys, so we don't require that you use certain surveys. We give you a choice of ones you probably already use and are already in your EMR, like the PHQ-9, the GAD-7, the BAM, the BARC. And there are others, but we don't require any one, which is both good and bad. Bad because we don't have the same survey from everybody, the same outcome survey. But good because it doesn't really require treatment centers to do much different. They often are already using one of these, and it can just be pushed without action on their part as soon as their patients complete a survey. So anyway, that's the status of the program. Our most recent report is available online. This is the summary report. It does not, it is the aggregate of data, so everybody's data. And I can provide a link to that as well. I should have put that in the chat, or I had that at the ready. But within the report, there's a list of all of the participating treatment organizations across the country. And at the time, it was a smaller number than we have now. But you can see there's a pretty big diversity in the types of programs. There's some really big ones, like Karen is very big, Gateway Foundation, Gaudenzia is big. Then there's some really little ones, some ones that are, 12 beds, 6 beds, and others that have multiple locations in multiple states. Some are nonprofit, some are for-profit. Most take insurance, and then there's probably about a quarter of them that are take Medicaid and public funding, like SAMHSA funding. So it's a really diverse set of data that's not available anywhere else. CMS has Medicaid data, and SAMHSA has data from the sites that they fund. Insurance companies have their own set of data, but this is data from all different kinds of treatment centers and all different kinds of care. As I said, there's, anyway, I'll get to that. Okay, I just wanted to show you a couple snippets from the report, just the kinds of things that we report. The SUD diagnosis, and it's hard to identify a primary diagnosis, but oftentimes we can do that, or the patient specifies. But we're seeing mostly alcohol in this set of data. Lots of opiate use disorders, stimulant use disorders. But we're starting to answer questions that have been asked of the field for a long time, like what's the average length of stay in different levels of care? We get asked that at NAATP a lot. What's the average residential stay these days? And that data isn't readily available. So now we know in our data set, it's 22.4 days on average. There's a big standard deviation, so there's a lot of variability. But we know, we're starting to know a little bit. We know that, I didn't put this slide in there, but AMA rate. A lot of, we get asked that a lot. What's the average against medical advice discharge rate from substance use disorder treatment? I believe our last estimate was about 16%. So if you're below that, that's, if you know your AMA rate, great. But this is a way for you to see national data or aggregate data from lots of treatment centers and compare your own to that. This is just an example of one of the outcomes graphs from our report. This one's the PHQ, which is a depression screen. Lots of organizations use that. It's a pretty dramatic one because you can see from admission to discharge and onward, the PHQ is pretty dramatically reducing from the average score from a moderate range of depression down to a mild or minimal range and staying that way throughout early recovery. Now, yes, as you can see, the response rate post-discharge is dramatically lower. So it's hard to make a lot of valid conclusions from that. But as we're doing this project, we're learning a lot about how to get surveys done from patients because we care about patient report. We want to know what they're telling us. And we want to stay in touch with them throughout care and after care to make sure that they're doing okay. So this is just an example of a graph. When we send the individual reports to each participating facility, they would be able to see their data superimposed or next to the aggregate data. And yes, it's not apples to oranges, perfect. If there's some of you that are more research minded are saying, wait, are all the treatment centers in there and all the different programs? Yes. So that's why we're building a dashboard so that we can filter out, let's compare just residential programs or, things like that we want to look at with a little more specificity. And then these were some of the findings we've had so far. I think the first one is something we've known, but it's really nice to see it in our own data that people who participated in more than 30 days of care at any level of care, overall, this is just overall summary, were 65% less likely to relapse. Now, that of course is the term relapse doesn't apply if you're not a more abstinence-based, abstinence-based program. But we do also have data points about harm reduction. So we're not just looking at relapse, but that was one indicator a lot of treatment centers were interested in. So we did find that that output there. Lots of information about how high psychiatric acuity at admission really makes a person more likely to relapse, to leave treatment early. So we really have to be treating those patients differently. And that's an important finding. And then overall, you can see in the course of treatment, 42% decrease in symptoms of depression, also some significant decreases in anxiety, and of course, in substance use disorders. So this is the kind of thing that we've wanted to see for a long time as providers, and we now can see it in our own data. As I mentioned, if you are BestNotes customer, you can participate in this very easily. What we provide as benefits is assistance if you are not using measurement-based care during treatment. So standardized surveys used at different intervals during treatment, we can help you set that up. Or we can help you with protocols or help you understand, how to get your staff on board with this. Not all staff wants to do measurement-based care a lot of times. And then we also help you with comparing, of course, your data to other organizations. That's what the reports do. Some of the facilities involved in FoRSE have used their reports to communicate with CARF or their accreditation bodies, with their payers in contracting, and of course with the public to show their impact. And then there's opportunity to be involved in research, which of course demonstrates commitment to evidence-based practice. And of course, we need this data to create research to support public policy efforts to get more people care. So that advocacy piece is really important because advocacy doesn't hold as much weight if it isn't supported by data. So this is the way to sign up. You just express interest. I have my our email at the end here. There is an agreement we need to sign, and that is basically covers how we keep your data confidential. We never put your facility's data out there for the world to see. We only reflect it back to you. Then once you're signed up, then we say, okay, well, what do you want to share with us? And do you need help with implementation of surveys? And then you receive your annual report and use that to support your operations and communication. So then just to be more specific to BestNotes, the way we get those data points about the patient and the service, there are a few items that need to be populated into FoRSE surveys that are available in BestNotes. It's a very small number of data points that can be done by an admin staff or doesn't have to be done by a clinical staff person. But then as soon as those are completed, they're pushed to us. And then those are the options of the patient completed measures. So BAM, BARC, GAD, PHQ-T, and WHO-QoL-BREF. And then we also do have two that we created that are FoRSE specific that really came from provider interest. Those who said, like, for example, the relapse question, that's in the FoRSE discharge survey. A lot of providers wanted to know, are my patients relapsing? And then for others who don't track that term, they don't use that. So that data point. Progress monitoring survey is nice because it's really short. It's only 6 items and it asks about for during treatment. It can be used in outpatient or even residential, but it does ask about substance use, cravings. It asks about the therapeutic alliance, which is really helpful for your clinicians to know. So there's lots of benefits to implementing even one survey if you're not using any. If you're already using these surveys, great. You can be part of FoRSE very easily. So I think that is it. We can go to questions. That's an email that will get you right to me. And I'm gonna get out of the thing here and stop sharing. Oh, I stopped sharing. There we go. Yeah, so hopefully that gives you an overview of what this program is. One thing, you don't have to be a NAATP member to participate is one thing to know. So you don't have to join NAATP. You can just join FoRSE through BestNotes and through us, and then we'll get your de-identified data and help you understand it. So any questions?
There's none in the chat, but just wondering, what is some of the feedback that you have heard from outside organizations that have seen the annual report, or feedback from programs that have been participating so far?
Sure. We get lots of feedback on the annual report because that's a public document and people often just thank us for putting that out there. You know, this is the kind of thing they want to see about what happens to people in addiction treatment. Let's see, we've had a number tell us they used it in their CARF survey. In fact, I get emails every once in a while, when are our reports coming? Our CARF survey is coming up, because CARF or Joint Commission both require standardized measures to be used during care. And so they want evidence of that. And so this, of course, your annual report will show clear evidence that you're doing that. And in fact, it'll show some of your what we're seeing in your outcomes. And so that's really interesting to accreditors who want to see evidence, not just of measurement, but of quality care. And then, like I said, we've heard a couple who have said they've used it and they thought it was helpful in their contracting. I think it's challenging with commercial insurance. We look at patient-reported measures because that's what's important to us as clinicians, I think. Payers are often more interested in the data they already have, which is healthcare utilization data. But there's lots of recommendations out there from public agencies and organizations, nonprofits, saying we need to pay more attention to patient report. So hopefully that tide will turn, and payers will be more interested in quality of life and things like that as reported by the patient. But that kind of depends on your payers at this point. So
For sure.
yeah.
What policy recommendations have emerged from the FORCE data, and how can treatment providers contribute to advancing these policies?
Ooh. Um, so the policy, I think, I'd really like to see expansion we'd like to see expansion of Medicaid to cover as much addiction treatment as possible because a lot of people, that's what they have for insurance. And just expansion of payment for people who don't have insurance to get help. We feel that if we show the clear benefits of care, that it will be more likely to be reimbursed. That's really what we're hoping for. We really try to shine a light on healthcare inequities. So, disaggregating data by demographics and by social determinants to really say there's a lot of people who really need this kind of service but aren't receiving it. So those are the kinds of policies we hope to we hope will change, so that more people, regardless of their resources, are able to access care. So I
Wonderful.
don't know if I answered the whole question.
Yeah, that's
Okay.
great. Are there specific training or professional development opportunities associated with Force project with the Force project that counselors should pursue?
I would say if you're not familiar with measurement-based care, there's lots. We don't have one. I think that's one we'd like to build, but uh, that's something to look up. There's lots of resources. The Kennedy Forum is a good resource on measurement-based care. But we do a lot, if people ask us questions, we'll do a lot to guide you to what resources you need. We get a lot of questions about best practices and post-discharge survey, like do incentives work? How do you increase the rate of response? And so we can try to guide people there. I think first step is just contact us, let us know what you need. If we don't provide it, hopefully we can find you someone who does.
Wonderful. What are the future goals or next steps for the Force project? Are there any new
Oh, yeah.
initiatives on the horizon?
Yes. So the big one is the dashboard. Um, that one will have a cost. That one will be a software that people can choose to have or not. And so we don't know the price point yet, but we're having actually next Monday a focus group about to look at the dashboard. The dashboard will show, the data in real time. You don't have to wait for an annual report. So plus it's filterable. You can filter by level of care, by demographics, by data by age and things like that, by year of admission to look at different years. So it's a very cool software, but so that's what we're most excited about right now. But we're also really just trying to improve the quality of our reporting and make more partnerships with researchers and things like that. So lots on the horizon. Those are the big ones.
Wonderful. You may have already kind of touched on this, but we could maybe reiterate what are some key metrics or outcomes we should be tracking in our own practice to align with best practices promoted by the Force Project?
Yeah. So key outcomes. We've got to figure out this discharge type issue. Whether patients complete treatment or not. We have that's one thing we have to know. That's the easiest outcome is are patients completing, and what does that mean? If they're leaving, why are they leaving? Is it finance? So we just added, we changed some of the data points this year, and one of them we added was a financial discharge because we want to track how many people are leaving because they can't afford it. Because that's, again, with that policy advocacy, something that we want to make sure we understand why people are leaving. Another one is we added readmission rate because that's very popular with payers. It boggles my mind a little why readmission to treatment is considered a negative outcome, because sometimes if the person is still ill, they need more treatment, and that's that doesn't mean the treatment failed, but so we did add that so we can track readmission rate. So just by indicating for each patient, is this a readmission or not? then that's something that you can see and benchmark yourself against other centers. So that's something I think would be good to track. And then the others is just whatever ones of those patient-reported measures that are useful to you. If you do any treatment for co-occurring mental health, the PHQ and the GAD are great. The BARC is, if you're not using a recovery capital assessment, that's a free and easy and short one. Recovery capital is talked about all the time, about what's nice about it is you get to see it going up rather, in treatment rather than just, decrease in symptoms. We get to see something increasing. Are your patients growing in self-esteem and hope and friends and connection to community? So that's a really valuable outcome to track. Those are the ones that would pop to mind.
Those are great. That's really, I think those are really important and really applicable to our population that uses BestNotes. So,
Right. Great.
how do you see the role of technology evolving in addiction treatment based on FoRSE's research?
Oh, we want any technology to be able to connect to Force. So we just, are trying to get, even apps, to push data to Force. But, I think however data is collected, the important thing is that we don't look at it just in our own center, that we look at it together, because more data means more power to do research and to answer some of these big compelling questions. So technology, and the better we get at sharing data in a safe way, is gonna really improve what we know about healthcare. I think AI has innumerable uses in the conclusions we can make, the insights we can find in the data, and also the different kinds of data we can collect. What else? Yeah, I think somehow we've got to figure out this, how to stay in touch with people, for a long term. That's something I think technology will help us solve. We haven't quite figured that out yet. How do we stay in touch with people for a long time? Some people are using wearables, but doesn't tell the whole story. So, there's lots that tech companies can do. And, we love to be united with, if we have tech, research, providers, policymakers all at the same table, payers, then that's when we can really make a lot of change happen.
Yeah. Love the project that you're working on. We have always talked about here that the more data you have, the more questions it opens up. And
Very true.
so, uh, just excited to see the questions that are going to come up as you continue gathering more information and get more. We will help in getting more programs on board with FoRSE. And
Yeah.
thank you, Annie, so much for your time today
Yeah.
and
We
for
do have a question just came up.
on the
In
chat.
the Yeah, can individual providers be part of this? For sure. So even if you're private practice, if you collect this data and it's in BestNotes, or you can get it into BestNotes, then yes, we have very small clinics. I'm not sure we have any single practitioners, but you could be the first, if it's just you or a very small practice. We do have a couple of those. So yeah, if you're using BestNotes, the data's there. We figure out what you want to send to us, and we can make that happen.
Wonderful. Perfect.
All
I
right.
don't think
Thanks
there
so
are any
much.
other questions. So thank you so much, Annie. Thanks for attending, everyone. And we'll be in contact here with a copy of this webinar. We'll email it out to you. So thank you again.
Thanks
Have a
all.
wonderful day.